everyone. This program is going to be recorded, but only the host and the panelists will be recorded. I wanted to open with our land acknowledgement. The Whitby Public Library acknowledges that we are on the treaty and traditional territory of the Mississauga of Scugog Island First Nation. May we respectfully honor the knowledge and understanding of the Indigenous stewards of these ancestral lands and ensure that the voices of the First Peoples are represented in our collections, programs, and services. Tonight's talk is about palliative care. Representatives from Vaughan Hospice, Ridges Hospice, Home and Community Care Support Services, and other palliative care providers will be joining us for an educational talk on palliative care, death and dying, and the Compassionate Communities Initiative. This presentation will be followed by a discussion and a chance for you to ask questions. All right, take it away.
All right, so I think I'm first up. I'm Dr. McAllister, and I'm just getting my slideshow going. And all right, so the title for today's talk is Advanced Care Planning. And I'm a family practitioner in Brooklyn, and I've been practicing palliative care in the Whitby-Oshawa area for about 15 years now. And the reason why I wanted to kind of bring this group of people together and give this talk is because of a nationwide meeting that I attended last February. It's for all the specialist palliative care providers, and they started talking about an initiative called the Compassionate Communities Initiative. And what that initiative is, it's basically just a way of trying to promote public health education about palliative care and helping promote communities to become more compassionate towards people who have life-limiting illness or severe illness. And so I thought that one great forum for doing that would be through the public library, because they provide great education for many people. And so I reached out to Suzanne, and she was kind enough to give me this opportunity to talk. And I roped in a few people who I know who have lots of experience and provide great care in the community. And so we're just going to give you a talk on advanced care planning and palliative care today. So, I'm going to start by saying, what does planning involve? All right. So when we're planning something, we have to establish what's desired, what do we want, and what is available and what's advisable. And then somehow we mash those two things together, or three things together, or all the pieces of information together, and we come up with a best fit, right? So, for example, what do we plan every day? Well, we plan what we're going to eat, all right? What we like, the food things that we prefer, the preferences, time of day, not everybody likes to have fish for breakfast. Availability, how many people are there who are going to be eating? Healthy choices. What's available, right? What's in my fridge right now? What can I afford to buy? How much time do I have to prepare this, right? So, for example, in my house, my kids are all growing up now, but I have three, and for breakfast, my daughter, she's a vegetarian, so she does not want bacon and eggs. My sons, they love bacon and eggs every day, but I don't have time to make them bacon and eggs every day, right? So we have this kind of dance about what are we going to have. And a lot of times if it's a busy weekday, then we have Cheerios and a banana because that's fast and everybody will eat it. But if it's a weekend, we take a bit more leisurely and have pancakes on one day so the vegetarian's happy, and, bacon and eggs on the next day so the other two are happy, right? So, we take what's desired, we take what's available, we put it together, and we come up with a plan that we hope satisfies as many people as possible who are involved in the decision making. So what else do we plan? Well, what do we plan every week? We plan lessons, we plan visits with our friends and family. We just had a wonderful Thanksgiving that I hope lots of people had an opportunity and plan towards who's bringing what, right? We plan our house week, who really is going to clean the toilets this week, right? We plan our grocery shopping, we plan our leisure activities. We plan once a year, we plan holidays, right? It'd be great to go on a round the world cruise, right? But you have to have a lot of money, you have to have a lot of time, you have to not be during a pandemic, right? So I'm on holiday right now, and what I could plan was 2 nights away at Blue Mountain with my husband, right? And it's not ideal, but you know what? I'm still really looking forward to it. So, have to take what do I want and what's available. What do we plan once in a lifetime? We plan weddings, right? We plan funerals, but not so much. So how successful are we in our planning? Well, daily, right? We eat, we get dressed, we go to school and work, 99% of the time we manage those things. Weekly, anybody who lives in Whitby and Oshawa and has children or grandchildren know that hockey reigns supreme. You never miss a game, right? So we're pretty successful there. Yearly, most people will plan a trip or an outing of some sort. Lifetime, how successful are we there? What do we not want, but we still plan for, right? So financial hardship. Now, the statistics I've given you, really, they're Dr. Google statistics. So I just found them off the internet. I'm not 100% how accurate they are, but they give you the gist of it. So financial hardship. 3 in 10 Canadians couldn't pay their bills if they lost their job right now. But that means 70% of Canadians have planned for financial hardship, right? Illness. People have disability insurance. 50% of Canadians have disability coverage of some sort or another. Divorce. We don't like to plan for divorce, but 8% of Canadians actually have prenuptial arrangements. So there's lots of things that we don't want to think about or we don't want to happen, but we still will make plans for it, right? So what about end of life, right? What percentage of Canadians have a will? Well, if you look at the statistics, it says 51% of Canadians had a will prior to the pandemic. And if you look at why people don't have wills, there's lots of different reasons. But interestingly, I was really surprised. Only 8% of respondents said that they didn't have a will because they didn't want to think about dying, right? The business of dying is something that people do think about. Who's going to get my china? Where it's going to what's going to happen to my house? Who's going to look after my cat, right? These are things that people want to discuss, 92% of people. But when it comes down to the nitty gritty of the dying process or what happens in your last months, days, weeks, right? That's not as well talked about. A recent Canadian study found that in elderly patients who are hospitalized, who are really very close to the end of their life, like we expect end of life in upcoming weeks, 75% of those participants had actually thought about the care they would want at the end of their life. And 90% of those people had discussed it with their family member, right? And I know those numbers actually sound pretty good, right? But when you look at the cumulative statistic, right, the soon have had a conversation with their families about their end of life wishes, right? And it's interesting because if 68% of these people have had a conversation, but only 8% of people don't want to talk about dying, there's still a big gap there. There's something in these numbers that don't add up. And we find that often when we talk about palliative care, right? More numbers that don't add up. 75% of Canadians report wanting to be in their home when they die. But if you look at the most recent statistics in the Durham region, we've not been doing very good because 65% of Durham residents actually die in a hospital. And we're hoping that that will improve and change over time. But, numbers aren't adding up. So one of the things I do ask myself when I see these numbers, because I think that we do a pretty good job, right? Is, are we measuring the right thing? So, is palliative care really only end of life care or terminal care? If you look at what the WHO definition, so the World Health Organization states that palliative care is an approach that improves quality of life of a patient and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. So I found this nice graphic here, and it kind of shows you that palliative care is not just terminal care. And I don't really like that term, but that's what they've put on this slide. So that's what I'm using. It really involves, treatment and advanced care planning and symptom management from a very, very early stage when patients are diagnosed with what we know will be a life-limiting illness. So phase 1, the gray phase, is early on, usually shortly after diagnosis. Phase 2, the lighter blue color, they term that end of life care. And then phase 3, the bright blue, is just kind of the terminal care. So palliative care involves advanced care planning, and that's the process of reflection and communication to let others know your future and personal health and personal care preferences in the event that you become incapable of consenting to or refusing treatment or other care. And that's the focus of this talk, and there's going to be lots of examples of that later on. Symptom management means the use of medications and other means to maximize quality of life. And I'm not going to spend a lot of time talking about that. That's very medicalized care. That's care that's carried out on palliative care wards. That's care that's carried out in the communities when there's a physician involved. So I'm not going to focus on that. When we're talking about making decisions around palliative situations, very many different things come into play. There's psychological considerations, there's medical considerations, there's physical considerations, and these are all components to the decision-making in these areas. And I'll try and highlight that a little bit later. So as a physician, a lot of the stuff that we learn or how we learn is case-based, right? So, you know, in medical school, a patient comes in, they tell you their story, it's more meaningful, it sticks in our brains. And so I'm just going to kind of revert to that because that's what I know how to do. So I'm going to talk to you, and we're all going to talk to you a little bit about Donna. Now, Donna is not a real person. She does not reflect anybody who I've actually ever met. I just kind of made this up, but it's not an unusual story. She's 67 years old. She has a new diagnosis of breast cancer. She lives in a bungalow with her husband, who has dementia, and his dementia is certainly moderate dementia. So, you know, he can get dressed in the morning on his own and he can toilet himself. But to know how to go from step A to step B, what breakfast is, where lunch is, how to get in the car, you know, when he has to go to the grocery store, he can't do those things on his own. And for us in palliative care, social circumstance is very, very important for planning. So you'll find that we ask you many, many personal questions, and people sometimes get put off by that a bit. But it's only because without understanding the context that you are in, we can't help you plan in the right way. So Donna and her husband have 2 children. Their daughter lives in Toronto and their son lives in Orillia. She attends the Durham Regional Cancer Center for chemotherapy, and she has some back pain that's relatively mild. She started taking some Tylenol for it. So this is Donna. She's in phase 1 of palliative care. And sometimes these patients don't need a lot of medical care from doctors. And they often require supports and services that can be offered through VON Hospice. And these supports and services carry with the patient through their whole journey. So I'm going to hand off now to Disa and Renuka from VON Hospice, and they're going to talk a little bit about VON and the services that they offer.
Thank you, Dr. McAllister. So as was mentioned, my name is Disa, and along with Renuka, we are from VON Durham Hospice Services and the Palliative Care Community Team. So the VON Durham Hospice Services team can support Donna and her family from the time of her diagnosis and all the way through to end of life, and support her family through to bereavement as well. Our focus is working with the whole circle of care to provide a holistic, person-centered palliative approach to care. We work from a multidimensional perspective and support the individual's physical, psychological, social, spiritual, and practical well-being. In terms of referrals for VON Durham Hospice Services, these referrals can come through a variety of community team members, such as doctors, home care, or nurses. But individuals and family members are also able to self-refer to VON Durham for any of our services that we'll talk about. So all you need to do is call our office and our intake team leader can review our services with you if you're interested in. So the first service that we'll talk about is the Hospice Navigator. So Renuka and I are both hospice navigators. We're registered nurses with expertise in palliative care, and we can provide ongoing support to Donna and her family while they're navigating their illness journey. So this can include linking them with other palliative care providers or community resources, providing psychosocial support, education, and advocacy, and generally helping them navigate the healthcare system. We also would provide support to Donna and her family with advanced care planning and the conversations and plans that Dr. McAllister will talk more about during this presentation. Donna can also be supported by our supportive care counselor, who provides emotional, social, and spiritual counseling to individuals experiencing a life-limiting illness, as well as their families. The supportive care counselor can help Donna or members of her family that live in Durham Region in managing stress, maintaining positive relationships, and developing coping strategies. One can experience so many different feelings and emotions when living with a life-limiting illness, and it can sometimes be helpful to have a professional counselor to work through some of these challenges when they're getting overwhelming. So while this service wouldn't be available to Donna's children living outside of Durham, we would be able to help refer them to organizations in their region to help support them there.
Okay, and moving on to the hospice volunteer supports. So our community hospice volunteers are an important part of the holistic approach to care. The volunteers at the VON can provide companionship, emotional, and psychosocial support to the individual they're matched with. In addition to the training they receive at the VON, they also come with their own knowledge and expertise. They bring a passion for helping others, and with that, they can also support with advocating for the individual that they're matched with. In the case of Donna, our palliative care coordinator would reach out to her and try to match her with a volunteer based on who she thinks would provide the best support for her. So maybe she would prefer to be linked with a volunteer of same faith or cultural background, or perhaps Donna was passionate about gardening, and so she would prefer to be linked with a volunteer that has that same interest. Or maybe she's interested in being linked to a volunteer that's provided care for a loved one with dementia. So once that match has been established with a volunteer, the volunteer would then check in on Donna on a weekly basis and provide that peer-to-peer support, and that will fall under our one-to-one volunteer program. Secondly, we have a group support programs for individuals, again, with a life-limiting illness, and that's called the Day Hospice. This program runs every Thursday from 10 to 12 noon on Zoom and allows participants to connect with each other and have the opportunity to talk about their experiences, and also have the opportunity to support each other. During the hospice day program, they're able to learn new educational topics and also engage in activities, which with that engagement allows them to learn in the process. We also have support programs for caregivers, and in Donna's case, which could also benefit her as she's caring for her husband with dementia. The one-to-one volunteer program is also available to her, where in the VON, Durham offers a caregiver achieving resiliency and empowerment support group, which is also done in Zoom. Similarly to the Day Hospice group, this program allows caregivers to connect with each other and to have the opportunity to share their experiences. This is done through a monthly educational series. There's bi-weekly support group and also a monthly drop-in group. Again, these caregivers supports would be available to Donna's family. Sorry, wouldn't be available to Donna's family that didn't live in the Durham region, but if her children are in need of that caregiver support, our team are more than happy to link them to the appropriate services in the areas that they live. And last, we've got the palliative pain and symptom management consultant, who's also available to support Donna's symptom management and palliative care needs by supporting the healthcare providers within her care team and providing them with consultation, education, and suggestions to improve Donna's comfort and quality of life. Pass it back over to you, Dr. McAllister.
Great. Let me just get my screen sharing going here again. Is it up there? 1 second. Zoom, so much fun. All right, okay. All right, so just getting back to kind of the 3 phases of palliative care. So getting into phase 2, we're going to talk about it a little bit more. So the question here is, how does the community palliative care team on call help Donna? So I'm really mostly talking about physician care here. So for patients who have cancer, palliative care is like almost synonymous with cancer. Everybody assumes that people who have cancer are going to require palliative care. And in our area, for patients who require palliative care who have cancer, if they go to the Durham Regional Cancer Center, and if they're in phase 1 of their illness, but they're having significant symptoms that need controlling, they will be referred to our outpatient clinic and be seen by a palliative care specialist. For people who don't have cancer, it's not that these people don't deserve palliative care, they absolutely do, but it's very difficult for us to provide care to everybody who has heart disease and congestive heart failure and COPD and dementia, right? There's just not enough of us around. So for phase 1, most of that care is provided by their family practitioner or their nurse practitioner. And the palliative care involves, as I said, advanced care planning, right? Conversations that we're going to talk more about in a minute, but also symptom management. And there are lots of family doctors around. I'm a family doctor, right? So there's lots of family doctors around who feel very comfortable and competent doing palliative care, providing palliative care. And we really find that for the most part, we get referrals at different stages. Many don't want to do phase 3, and that's just because they don't want to be on call 24 hours a day, 7 days a week, right? So when patients are getting to the point where they're having lots of symptoms that require titration or changes of medications or things like that, typically when the patient is unable to leave the home, they get referred to a local home visit team. And those teams are termed the Palliative Care or CPOC on call, Community Palliative Care on call. And these are specialized groups who have extra training in palliative care as physicians. And they are available in Ajax, Pickering, Bowmanville, Port Perry, and Oshawa Whitby. And these groups have special funding through the ministry to be able to be on call. Sadly, with the exception of the Port Perry group, they didn't qualify for this money, not because they're not competent. They're great. There was something about their numbers. And as I said, numbers in palliative care don't always add up because they're a really good group. And so they volunteer to be on call 24/7 out of the kindness of their heart. So priorities in phase 2 of palliative care, and I put end of life care, and then I put a little sad face to tell you again, I don't really like the term end of life care for this group of patients because, you know, we're often providing care for some patients in palliative care for 6 months, 12 months. I looked after one lady for 5 years, right? Because she had cancer and she had very significant symptoms. And so I don't really like end of life care as that term. So this is just kind of phase 2, which means I'm not early in my diagnosis, but I'm not right at the very end of my life, right? So our primary goals as physicians are to establish a substitute decision maker, if this hasn't already been done, because VON Hospice mentioned this advanced care planning is part of what they do. The other person who can also establish the substitute decision maker is a lawyer, and I'll go into this a bit more in detail in a second. We confirm goals of care. And again, these conversations may have been held before they end up in our purvey as palliative care physicians. We discuss possible complications, we provide symptom relief, and then we prepare for a terminal end of life. So talking about substitute decision makers. So a substitute decision maker is a person who is entitled by law to make health decisions on behalf of an incapable person, right? So we all have an idea of what we want, right? By law, in Ontario, if you haven't appointed or don't have somebody in the yellow side of this table on the right-hand side, the person who will be making decisions for you is your spouse or your partner. If you have no spouse or partner, it then falls to parents or children. If you have 5 children, all of them have an equal say in what has to be done, and it has to be a unanimous decision, right? So the decisions that are made by a substitute decision maker, whoever they are, should always reflect the wishes of the patient. And that's why it's so important to have conversations about what you would wish. So my mother may or may not be listening to this talk, but she's a lovely retired nurse. And she's told me, when I get to the end of my life, I don't want A, B, or C, right? So if we get to the end of her life and I'm like, oh my gosh, I really want my mom to be around for my daughter's birthday on Saturday, please do A, right? My mother will come back and haunt me from my grave or her grave. And what's more than that, I'm not being a good substitute decision maker because I'm not taking into account or advocating for what she wants. So power of attorney for personal care is a legally appointed substitute decision maker, and you can see it falls into the yellow section there. And so people who should really have a legally appointed substitute decision maker is a power of attorney for personal care is someone whose substitute decision maker is not the right person to be their substitute decision maker. So in Donna's case, you know, she probably should not have her husband as the substitute decision maker because he can't really understand what's happening to her. And he may love her very much, but he may love her so much that he doesn't want her to go, right? And so that he's not going to advocate for her choices. So she would be recommended to appoint somebody as her power of attorney for personal care. I had a lady who I looked after her whole family. She was extremely close with her daughter, and she appointed her neighbor as her power of attorney personal care. And she said, I love my daughter and I don't want her to feel responsible for what happens to me at the end of my life because I know that would be really devastating for her. And her daughter was so mad at her. But in the long run, knowing her daughter, I understand why she made that decision, right? So the thing about power of attorney for personal care, this purple thing that's all underlined there, if you go into Google and you look up power of attorney Ontario form, you'll find this link. Getting a power of attorney for personal care or a power of attorney for finance is not costly, and you don't actually have to go see a lawyer to get it done. If you print this form, sign this form, the most complicated thing is picking the person and getting 2 people to witness your form, right? It costs nothing. If you do have a power of attorney for personal care and you're presenting to the hospital for care, or you're presenting to somebody, a physician for care, or an agency for care, you may be asked to present this information just so we can make sure that we get the right decision maker. So that's about substitute decision makers. Goals of care. So this is really, really important and probably the most important part of my talk. In our world of medicine, we have 3 different levels of care. The first is full aggressive care, and that includes an attempt at resuscitation and ICU admission. So some people really want full aggressive care, but they're not going to be successful in their full aggressive care because we know that resuscitation is not going to be effective. All right. Active care means I don't want to be resuscitated, or I don't want an attempt made at resuscitation, and I don't really want to go to the ICU, but I do want other things. So if I have cancer and I'm having horrible crushing chest pain, I would like to go to the hospital, and I would like someone to see if I'm having a heart attack. And if I am, I'd like treatment for my heart attack, right? So for people who don't want aggressive care, they don't want resuscitation, they need to have a DNAR form. So that's part of the advanced care, right? Planning. Because otherwise, if they have a big heart attack at home and they don't have that form and they do pass away, the paramedics will have no choice but to attempt resuscitation, right? And I come across a lot of people who say, oh, well, I've had this conversation with my lawyer and it's in my will that I don't want aggressive measures, or I don't want heroic measures. And I say, that's great, but your lawyer's not standing in the room with your wife when the paramedics show up. They need an order from a doctor or a nurse to tell them not to resuscitate. So really important to have that form available. And one of the key take-home points for this talk is that people typically, when they move from aggressive care to active care, they're competent and they're making that decision themselves. So their quality of life is not necessarily where they want it to be. And they know that they have a significant illness and they have to go to the ICU, that their quality of life will never get back even to where they are right now. So they usually make that decision themselves. Comfort care is our 3rd level of care, right? And it's when patients don't want any more treatment. So the person who's home having, crushing chest pain, they're saying, I don't really want a stent placed. I don't want an angio cath done. I don't really want another blood test to find out if I'm having a heart attack. I want pain medication. I don't want my life to be longer now, right? And so treatments that are involved in this are things like IV antibiotics, IV hydration. And that's one that a lot of people have a hard time wrapping their mind around because, the concept of not providing fluids at the end of a person's life, people are really worried about that. And there's some really good spiritual and religious reasons why people do want hydration. But for the most part, most patients in our world, most people, most human beings actually die from dehydration. Because when you're not drinking, because you're too weak to, because you're having a bad exacerbation of congestive heart failure, or you have terminal cancer and you're confused a lot of the time, when you don't drink, you become dehydrated and your kidneys don't work and you get into this kind of pleasant euphoric state, right? And then you pass away. So when people are looking for comfort care, a lot of families have a hard time understanding that providing fluids doesn't actually provide comfort. And so we spend a lot of time educating around that. And the big thing to note is that when people move from active care to comfort care, it's typically their family, their substitute decision maker, who's making that decision about when to move to comfort care. And it's not always them, but it often is, because when people are getting to the point where comfort care is what they're looking for, they're often not competent or capable any longer. That ability to communicate, to fully understand what's going on, what their choices are not there. So that's why advanced care planning is so important in patients who we know are getting into their last months of life, right? So that the substitute decision makers can make decisions based on what the patient would want, again, not based on what they would want. Okay, so complications, right? That's another big thing that the physician team does, and also the nursing team as much as they can. They're going to talk to Donna about the complications that might happen so that they can talk about figuring out how and what level of care she wants. So one very common complication that happens to patients who are on chemotherapy is they can have a side effect where their white blood cells that fight infection are decreased. And so as a result, the bacteria that live in us and on us start to invade our bodies, including causing infections into our blood. So this is a very serious thing. This is called sepsis. And for some people who have sepsis, they need support in an ICU, right? They may need to go on life support. They may need to have a tube put down their throat. They may need IV treatment with special chemicals to bring their blood pressure up. So that would be aggressive care. Active care would mean, you know what, I don't want to go to the ICU. And if my heart stops, I don't want resuscitation, but I still would like to go to the hospital. And I want IV antibiotics if this is going to make me better, quote unquote. Recognizing that people, even when they get better, usually aren't quite at the level of function that they were at before they got sick. Comfort care would mean I have a fever because I'm septic, so I'd like some medicine for my fever. And because I'm really weak and I can't move around in bed, I'd like some treatment for the pain that comes with immobility. And if I'm getting fluid on my lungs because I have pneumonia or something, I'd like some medication for my shortness of breath. So planning involves kind of having conversations around things that might happen. So Donna can explain to her family kind of the things that are important to her. And we provide education. We provide education on, these are some practical questions, right? Physical, medical situations. Where is an ICU bed available? My family laughs at me last year in February during the worst of the COVID crisis. I came home from seeing someone in the ICU in a hospital in our area who was in the closet and being cared for by a diabetes educator who actually hadn't done any bedside nursing for 20 years. And I said, nobody's allowed to use a power tool again. And we're not driving in our car anywhere, right? Because I knew it was available, right? So other things around resuscitation, physical and medical constraints are, can a person withstand CPR? So if you have breast cancer and it's all through your ribs, right, and we're going to try and resuscitate you, your ribs aren't going to make it, right? So an attempt is unlikely to be successful. Other really important things when people are making decisions, these are the medical pieces of information that sound really cold, callous that we give people, but the psychological considerations and the number of times I hear people say, I don't want to be a burden to my family, right? I don't want them to have to provide me too much care. Those are super, super important and really, really important for people to have a conversation with their family about what are the most important features in their life? What's important to them? Their independence, their ability to walk to the washroom, their ability to communicate. I always tell my patients, I want to be able to have a full and meaningful conversation with my kids so I can tell them what I expect from them moving forward. And if I can't do that and I'm not competent to do that, then I don't have a quality of life that's agreeable to me, right? That might not be what other people want, but I'm clear and I give them examples because to me, communication is very important, right? And the other really hard question that I ask patients to try and answer when they're trying to think about what level of care they would want to be able to let their family know to how to make decisions or their substitute decision maker is, what does life look like when I wouldn't want it prolonged any further, right? And that's a harsh question, but when you boil it right down to that, people are usually able to paint the picture so that their substitute decision maker or their power of attorney of personal care isn't wondering if they're making the right decisions, okay? So the primary goal of advanced care planning is to allow smooth transition from one level of palliative care, phase 1 to phase 2 to phase 3, right? So that people are informed, right? So there's not a lot of fighting happening at the time. There's not a lot of questions, right? They have an idea of what's coming next, right? What are some of the complications and what are the likely choices, right? And plans can only come to fruition if the desires have been talked about and if the education around advisability and availability of resources and treatments has been done, right? And it's also really important to know that, the best laid plans of mice and men don't always go the way we want, right? So oftentimes people have a plan A, this is what I want. But we have to look at, if plan A can't come to fruition because, it's not the desired plan or that's not available right now or it's not advisable right now, how can we move to plan B, right? So you can see that advanced care planning is very complicated. And that's why we really like people to start this conversation early with their lawyer, with VON hospice. So by the time we're providing them very complicated medical pieces of information, they're versed in these terms, they have an idea of what's coming, and we're able to help move through that planning a little bit better. So coming back to Donna, she's kind of getting into phase 2 now. Her daughter visits once a week to help her with her groceries and take her father out for a coffee so that Donna can have a few minutes or hours on her own. Her son comes on the weekend, 1 weekend per month, to do house maintenance. He cuts the grass and, fix the locks on the door, whatever he needs doing. She's still going for chemotherapy at the Durham Regional Cancer Center. Now her back pain's gotten worse and she's having to take opioid pain medications. And that's often a trigger in our world, in Whitby and Oshawa, to make a referral to a palliative care team. And often when medications are being changed quickly or we're concerned about symptom management, that's often when we're saying, hey, we need, home and community care in there, because we need a nurse in the home who can provide us information, who can provide education to the family. And so I'm going to hand off now to Melina, who's from Home and Community Care Support Services Central East. And she's going to tell us a little bit about the services that they offer for patients.
Hi, and thank you and welcome everybody. Sorry, 1 second. All right. Just when you think you got it together. All right, so thank you everyone. As Dr. McAllister indicated, my name is Melina Prawn. I'm a senior manager at Home and Community Care Support Services Central East, which serves Durham Region and much more. So I do manage the community palliative program here. So at Home and Community Care Support Services, which we were formerly called the LIN, which stands for the Local Health Integration Network, which some of you may be familiar with, or the CCAC, which is Community Care Access Center. So we've had many names over the years, and now we're just Home and Community Care Support Services. So we provide an array of supports and services in the community. Such services include coordination of care and system navigation, personal support work, nursing, occupational therapy, nurse practitioners, physio, dietary, speech language pathology, and a whole other bunch of clinical programs, including social work, some telehealth programs. So our care coordinators are dedicated nurses or occupational therapists, physiotherapists. Some are social workers who work directly with patients, their families and or caregivers, to coordinate the right care in the right location. So they complete assessments and have strong community partnerships to support patients through their healthcare journey. Another highlighted program is the Community Palliative Care Nurse Practitioner Program. So this is a team of dedicated nurse practitioners with expertise in palliative care, and they provide direct clinical or medical care to patients with complex palliative needs. This would include pain and symptom management, and often in a shared care almost type model with the physician group, or sometimes independently, depending on the situation. We have combined palliative care model, which is this model provides an enhanced and coordinated access to specialized palliative care 24/7 across our Central East geography. So the goal of this is that the patient and caregivers experience specifically related to pain and symptom management and quality of life in the final months of life would improve. It enhances the communication and improves collaboration. It also optimizes nursing and personal support resources. It brings the nurse and the PSWs together in one agency, which facilitates better communication and coordination within and across the teams, as well as improves the management if there's any delegated acts from nursing to personal support workers. So So how can home and community care support services help Donna? So we would look at setting her up for nursing to assess and support her pain and symptoms at home. Donna would have an assigned care coordinator to complete assessments and determine further needs and support with further system navigation and coordination of services when conditions change. This care coordinator would also be responsible for completing referrals to other community support services such as Community Care Durham for things like home help or Meals on Wheels, transportation. We would also do referrals to other community support services such as VON if they weren't already involved, or again, tapping into that advanced care planning of doing maybe a backup application to a hospice residence or a palliative care unit, depending on the situation. That care coordinator could help with further care planning by potentially reviewing the expected death package if Donna's wishes were to remain home for end of life. And then we would also help by reviewing and assisting the care required for her spouse who has dementia. So whether it be doing a long-term care home application or assessing him for additional services. Again, as Disa and Renoka mentioned, looking into adult day program and linkages to other community support services. We would keep open lines of communication with all members of the team to ensure that Donna is receiving the right care at the right time. And Dr. McAllister, I will give it back to you.
Perfect. Thank you. Okay. So again, just looking at our kind of pictograph here, looking at phase 3, right? So phase 3 comes, and having advanced care plans are very important because sometimes this comes sooner than any of us would like. And trying to have conversations when people are really not well is not fun. So from a psychosocial point of view, we're really going to confirm that power of attorney and personal care has been appointed, goals are clarified. And the thing that I haven't talked about, and unfortunately I didn't include very much today, is spiritual care needs. So I know VON did mention that. It is something that our team does try and address with patients to make sure that their spiritual care needs are looked after. They've been able to be in contact with their minister or their priest or their clergy or whoever is important to them. Because people who do have a faith find it a very important part of their journey. Medical changes, the bulk of our care, certainly there's a lot in phase 2 for people who are very symptomatic, but everybody at the end of life has symptoms of some sort that we need to support them through. And that requires medication, and it requires excellent care and education of the family on how to administer those medications and when to administer those medications. And this is where patients and their families need 24/7 support. And this is typically where we see family doctors stepping out, because to be on call 24 hours a day, 7 days a week is tiring, right? And even our team, we're not perfect, but we do the best we can. And so we are on call week by week. So one physician is on for a whole week for all of the 200 or 250 patients in the Durham region. And that sounds like a lot, but in Toronto, they have one physician on call through the Tammy Lettner Center for like the entire city of Toronto. So it can be done, but with really, really good communication with agencies who are in the home. So we work really closely with the visiting nurses, and we also work really closely with the families, right? So, you know, people from other areas come and they're surprised that the families are calling us directly. It's not uncommon at 2 o'clock in the morning for me to get a call from a family to say, I've already given her pain medicine, or I've already given them the medicine for such and such. I don't know what to do now. And so typically I just talk them through, right? This is the next thing. What has the nurse prepared, or do you need to call the nurse? Sometimes our team will go into the home right at 2 o'clock in the morning to help if there's a problem that can't be solved otherwise. But by planning ahead of time, you know, it makes it easier for the patient, it makes it easier for the family, and it makes it easier for the whole care team, right? Physical considerations in this phase 3 are very, very important. And this is the practical side of stuff, that there is no amount of MD or nurse involvement that we're going to be able to get our heads around. And that's the actual, how do you physically care for someone who's stuck in their bed, right? So the great thing is that all of these other service providers that I've talked about provide education to families about what's going to be expected, right? typically when a person is really approaching the end of their life, they're in their last weeks, right? They need somebody with them all of the time, right? And that's an able-bodied family member. So for Donna's situation, unless her family are going to take that time to be home with her, unless her children are able to stop working or take, compassionate care leave, right? She's not going to be able to stay at home because her husband's not going to be able to manage injectable medications or how to bathe her or how to turn her when she's too weak to get over in bed, right? So this is where having conversations about end of life and where you wish to be sometimes are not useful, because 75% of Canadians want to be in their own bed, right? That makes sense. But the practicality just is not there for several. So what are their options, right? If the home is not an option, well, I put 4F there. That's actually, I should have put Lake Ridge Health. So Lake Ridge Health Oshawa has a ward, 4F. That's the fourth floor F wing. That is our palliative care ward. And the palliative care ward has been in existence there for maybe about 7 years or 10 years. And before that, it was at the Whitby Hospital. So we've always had a place to care for people, but really until this year, we haven't had hospice residents in our area. And it's really sad because I think there's only there were, at the time when we were LHINs, there was only 2 LHINs in all of Ontario who didn't have a hospice residence. And we were one of them. And that's partly why that number of 65% seems high, because the palliative care ward is still considered a hospital location for end of life, right? So from the point of view of hospice residents, we currently have one in Port Perry, and I'm going to send it over to Amy Archer in a second. But there is going to be one built in Whitby, and there is also one going to be built in Clarington. And they are through Hospice, Durham Hospice, which is affiliated but not the same as VON Hospice, right? And I've done a little bit of work for them in the past, again, just publicizing and bringing awareness to the need for hospice residents. And so that's a great thing. And I'm now going to hand it over to Amy Archer, who is, I believe, the medical director for the, she'll correct me because I know I've got the wrong title.
Okay, Director of Care. Both.
Director of Care, there we go. Very good. So she's going to tell us a little bit about Ridges Hospice and end of life care.
Thanks so much, Carolyn, and thanks to the other panelists for walking us through this journey, and with Donna, showing just the incredible services that we currently have in the Durham region. And I think we, although we are not perfect, we have a great infrastructure to provide incredible care, because ultimately the wishes of individuals matter. They matter to them as individuals, to their families, and to the healthcare providers who are caring for them. And yes, we're slow out the gate to get hospices, but I think we are now on the great path to have a hospice residence, because the beauty of a hospice residence for Donna to consider, like the story unfolds, she doesn't have care provision in the home, or she may not. To ask adult children to stop their lives, perhaps they have children themselves in full-time jobs, and it really, for someone to stay home, we have put a lot of pressure in the healthcare system for caregivers to obtain that role as caregivers. And at the hospice, we have heard in the last 6 months, families say, it's so refreshing and it's been such a relief that I can just be her daughter and I don't have to be turning her and changing her, or that I can be her husband and I don't have to worry about not being able to give the care that she needs. So a hospice alternative provides a home-like setting and provides that 24-hour care that Carolyn, Dr. McAllister was talking about in regards to the practicality of caring for someone around the clock isn't easy, and it isn't something that everyone can do. So that is something that we would do at hospice residence. We have a compassionate care model that's free of charge. So we are funded by the ministry for 50% of our operations, and then we depend on the community fundraising initiatives, and that's to provide that 24/7 care. And it's delivered by a qualified care team. So we have physicians, we have nurses, we have PSWs, we also have allied healthcare professionals who are volunteers, who are kitchen volunteers, are making 3 a.m. Grilled cheese sandwiches, or providing that extra dessert at lunchtime, because eating for pleasure is very important for some of our individuals. We also have a team who is dedicated to pain and symptom management, And it just doesn't end there, because the palliative care approach incorporates those 8 domains of care. So the psychological, the social, the emotional, the spiritual. And so we also will be increasing our care delivery and having a supportive care coordinator come on board to help facilitate those emotional needs. And so the hospice is really a place where someone would consider coming for an end of life, so that terminal phase. And what that looks like for individuals can vary. And what we look at is a functional status. How are they functioning at home? Who's caring for them when they're not able to function on their own? Do they have the right support? We often say, or people think, that dying at home is exactly what they want to do. And when it comes down to it, we, had a man in the community, he said, I don't want my young children growing up in the home where I died. So coming to hospice is a place where they don't have to associate. And one of the young children, an 10-year-old boy, said, is this the dying house? Is this the house of death, was his language. And I was like, yeah, that's a great description of it. And so when Donna's considering coming to hospice, she could either, if she was still able and walking, she could come for a tour, or maybe her children could bring her for a tour, or we could have a virtual tour online to say, is this the care setting that I want to come in for my end of life care? Where do I want to receive that care? And putting in an application as part of planning ahead is getting us prepared to be aware that Donna's in the community and that Donna has a desire potentially to explore dying in the hospice residence. So she'll have an intake at the time when she puts in her referral, or maybe her healthcare provider puts in the referral on her behalf. And so there's some admission criteria that we look at. So we're looking at the whole picture, and we're looking at the person as an individual, and also as the family care needs. What does this person need? So we look at functional status, but as well as that psychosocial, emotional, spiritual, practical support that Donna may need. And so there's a stability criteria. So we really want to be taking people at end of life. So they may have, weeks to days to hours to live. So our team, like I mentioned, is really interpersonal care team, interdisciplinary. We also receive help and collaboration from the community. DISA has been part of our care delivery to help support individuals from patient navigation. Home and community care is essential in the care that we provide. Our physicians are essential in what we do as well. And so are the volunteers. They are the bread and butter of what we do in the hospice residence. So really when I remember the child talking about this being the death house, and I can appreciate that from a 10-year-old and how raw that is to talk about the place where his dad is going to die. And our conversation with him and with all of our residents and their families is that, yes, we may be a place where people leave after they have died. But it is also a place where we honor living and we focus on living. We have an opportunity. So because we have 8 beds and we have, a smaller group of individuals that we care for, the hospice becomes their home. We become a little family. We knew that this man, let's call him Paul for the sake of confidentiality, it was his birthday, and he was a farmer and he loved horses. And he talked about his granddaughter riding horses all over the world. And I had mentioned to him, we can have a horse come in the backyard and visit you. And oh, no. And he giggled it off. So it was his birthday, and I contacted where my daughter rides, talking about a compassionate community. This is the heart of what we do everywhere. And it doesn't have to be just in a hospice residence. It could be in someone's home, and it can be outside the hospital window. Or bringing them out into the front of the hospital. But so this man, Paul, loved horses. And so I called the local stable that was just around the corner where my daughter rides and said, hey, Brenda, just wondering, would you be willing to bring in a horse to visit this man? I know it would really, he never left his room. This was the first time he'd ever stepped foot on his back patio. He never went outside. His body image was impacted by his cancer that he had. And he was outside for an hour with this pony named Andy. And he even bent over to pick up grass to feed Andy. And he spent the whole time outside. It was amazing, incredible. And he died 3 days after his birthday. And as though he's sitting in this chair, there was a lot of, legacy work and memory making that he was able to achieve in the time that he was with us. So really special. Then we have a family on the left-hand side of the corner who this son chiseled this owl to have on our backyard terrace, and it says Oak Ridges on it, and he had spent months doing it, and his mom is still there, and they are just so grateful for the care that we are providing. And they weren't able to care for her at home anymore, and hospital was not her place setting, her desired place setting, and so the alternative was a hospice residence, and she's a local person and is really appreciating the care provision. She now calls us the hotel. This is the best hotel I've ever stayed at. And we're like, the Latin roots of hospitality. I love it. Hospice hotel. And I'm so glad that we're journeying with her. And then we have Maverick and our volunteer coordinator, Cheryl, in the corner, who pays some visits. We try to not tell public health because we can't sanitize this hand. So we make it few and far between visits, but pet therapy and bringing in people's pets is part of their family and is part of their home experience. And so Maverick has paid visit to some residents and offers some joy. So again, we really want to focus on the living part, and because it's a home-like environment, we get to do that. So once Donna would get to hospice or comfort tour, I'm just going to show you a video of our tour of hospice, if I may. Just have to switch screens here, so you can see what it actually looks like inside. So Oak Ridges Hospice is also a place where we are able to care for the whole family, and that they are just as important to us as the resident. It is really holistic care, and oftentimes we're making meals and having conversations in the dining room or in the library or in the family meeting room to speak with loved ones who may be sad, distressed, or just in wonder of what to expect. So in order to contact a hospice residence for Donna to make a referral, is she would come to either our website or have her healthcare professional to come to our website and do an online intake. So for community of Donna wanted to make her own referral, or her family on her behalf, or for healthcare providers. And it really highlights under these headings. I'll go back to my slideshow because I can't navigate the website if I'm on this form. So she could go to our website, which is provided in the chat. So thank you, Amanda, for doing that. And she would go to admissions. I'm going backwards. And again, like I showed you, the community or for providers. And underneath that heading, there's information that goes into more of when is it suitable for someone to come to a hospice residence. And that's really when they have, like I said, weeks to days to hours to live. And again, that home-like environment. And we do a holistic assessment. Our intake coordinator would get in contact with Donna and do an assessment of where she is in that disease trajectory to make sure that she's suitable and that we can provide the care in a home-like environment to meet Donna's goals of care. Pass it over to you, Carolyn. Thank you.
Perfect. Okay. All right. So Donna revisited. All right. Donna was admitted to Ridges Hospice, where she lived for 6 weeks. When Donna passed away, her daughter helped her father move into an assisted living retirement home. She frequently felt sadness when she thought about her mother, and she avoided coming to visit her father. And she remembered that maybe VON Hospice had mentioned something to her about, ongoing care that they could provide. So VON, over to you.
So I think we're just trying to put the slides up and then we can dive into the bereavement supports that are available through VON Durham.
Sorry about that. At the VON, we do have services for grief and bereavement. Those are programs that we do offer. So after Donna should pass away, or if family members are coping with other losses, we do have services and programs available to them. The bereavement services can be offered to anyone over 18 years of age living in the Durham region. And that loss can be a loss of anything, a family member, a friend, anything. And those are offered through one-to-one volunteer. It is a peer-based model that matches volunteers and clients that has a similar loss or have experienced a similar loss. And the support group, we also have the bereavement support group. I said this backwards. We have the one-to-one volunteer support groups, which is an 8-week program with a weekly phone call that can be up to 1 hour. Or we've got the bereavement support groups, which are also an 8-week program and can be 1.5 hour in length, which is currently done via Zoom. The different groups includes spousal loss, parental loss, mixed loss, which is general or multiple losses, and also pet loss.
And like Renoka said, these services are available at any point. So sometimes the need for grief or bereavement support doesn't come up right away after experiencing a loss. So if Donna's friends or family are feeling the need for additional supports a few months later, a year later, they can always reach out to our team. Again, like we said, these services are available to residents of Durham Region, but we're happy to find the appropriate supports for anybody living outside of Durham Region. And VON Durham Hospice Services Bereavement Program also offers various community events throughout the year, such as a butterfly release in the summertime and a tree of remembrance in the winter. Both of which would allow Donna's family to memorialize their loss and to honor her memory. And so we also have some education sessions. So one that's coming up on November 16th, which is National Bereavement Day, is a panel on post-death financial literacy. And these panelists will include an estate lawyer and a financial planner. And so this information may be helpful when thinking about advanced care planning and planning for death and the end of life. Thank you.
Okay. All right. So, okay, so we're at the end of our presentation, just a couple more little things here. So just summary philosophy, palliative care is a philosophy of care centered on improving quality of life in 3 phases. In the Durham region, there are many resources to help patients with palliative care needs, including the agencies that we've talked about today. And as some of the agencies have said, you know, you don't have to have your family physician to make referral to any of these agencies. You can make a self-referral. To access the palliative care physicians at the CPOC teams, there does have to be a physician-to-physician referral, but it's not uncommon that we'll get a call from a nurse in the community saying, I need some help right now, what can you do? So we usually always help. The statistics that we measure around palliative care, right, end of life, where do people die, right, are important. It's important for us to measure things because we only know if we improve, if we have some measurement to go against, right? But I think that I hope that we've given a good opportunity to show you today that palliative care is not just about where you die, right? It's about your whole journey in that last, you know, weeks, months, maybe even years of life when you have a terminal illness. And really emphasize the importance of making good, effective advanced care plans, right? You have to have an understanding of what a person desires. You have to have an availability of an understanding of what's advisable and what's available, right? So we've tried to provide you some education today about what's advisable, what's available, and there's lots of supports out there for people. And then just kind of the last word on advanced care planning, you know, planning doesn't always result in the desired outcome. But advanced planning helps promote the likelihood of success, right? And the satisfaction of the patient and the family, even if plan B is needed, right? So although my family's not happy when they get Cheerios and, you know, a banana, right? They know that they've contributed to the conversation and they know that they've been heard and they know that I've done my best and that they've done their best. And that's really what advanced care planning is about. So now what can you do, right? As the people who are watching this presentation, now that you have a better understanding, you know, we ask you to please go and start a conversation, you know, with your family or with a friend or with somebody about your personal health preferences. And if you don't know where to start, these are a few places. There's a couple of books. So over on the left of the screen is Talking About Death Won't Kill You. That's a book that I've just started reading recently, but has come highly recommended. Over on the right, there's a book by Atul Gawande, and that's a very good book. I'm going to talk a little bit more about that in a second. And then in the middle, you can see there's a website. It's called Speak Up Canada. And it's just important that you get on the Ontario website because, you know, some of the rules and laws around advanced care planning is different in different provinces. But it's got some good workbooks that you can work through on your own and then have conversations with your family about. So linking this back to compassionate communities, right? Because that's really what started me on this track, right? I really encourage anybody who's attended this conversation or this presentation to talk to others about what you've learned, right? If you think this talk would be useful for other people who you know, encourage them to go to the Whitby Public Library website and watch it, right? If you are a member of a larger community where you have an opportunity for live speakers, you know, one of the things that the ladies and I spoke about was this was a great practice run for us. We'd love to be able to provide this information in other forums to other people to promote education and promote compassion in our community. You could consider volunteering for VON Hospice, Community Care, Durham, Canadian Cancer Society. There's so many agencies out there that provide compassion to people, whether it's their palliative care or other people who have disabilities or illness in their life. You know, being part of a compassionate community is an important thing, and there are formal ways to do that. So the book that was on the right-hand side was called Being Mortal, and it's by Atul Gawande. And so one of my initiatives, other than this conversation, is to work towards doing a professional mediated book club, right? So there's like lots and lots of people who do book clubs out there. And I know a lot of people who currently work in palliative care, great nurses, other healthcare practitioners, retired individuals, the physicians that I work with, and what my vision is to try and allow people to have a mediator or a moderator at their book club to be able to answer some of the questions and point you in directions if you have questions. So the Whitby Public Library actually does have this book on offer for book club. And this probably is not something that's going to get started until the new year, only because it takes organization. But if you have a book club and you are interested in this, then I would tell you, please message Brooklyn Cares on Facebook. So that was a website that was set up a few years ago now to help with publication or publicity around hospice residents in the Whitby area, but it kind of serves as our touch point for various different things. So that's the end of our presentation. I just want to thank all of the speakers for their time this evening and their time in preparing this talk and the time that they're going to get roped into doing it again in the future. I want to thank the team that I work with at Lake Ridge Health Oshawa, because that's where the physician group is that I work with, and we have wonderful supporting nurses and a unit clerk there. And for all the community providers, certainly palliative care has been something I've enjoyed doing. I love talking to the nurses, and at even 2 o'clock in the morning. And I love the PSWs who can give me good information about what's going on with my patients and how they can really ambulate. And, COVID has been hard. It's been really hard on many of us. And having good community care, allow people to stay in their homes longer, allow people to die in their preferred location. And when they can't die in their location, provide them good care at the very end of their life. And then lastly, I'd like to thank Suzanne McNeil and also Amanda Price, who's hosting today. For ability to have this conversation, provide some public education on palliative care and the Compassionate Communities Initiative. And then I'd like to thank all of you for your questions. So that's where we're at now. And so questions can be to any of the panelists. And if any of the questions seem that they're too personal or we're having a hard time answering them, I believe that Amanda has a way for you to contact her. And then she can send the emails to me and I can farm them out to the appropriate people so we can contact you and provide you the information that you need.
All right, so I'm just going to stop recording in case anyone does have any questions. They won't be recorded. Thank you, just in case there is any, and thank you everyone for coming. So I'll just stop recording now.